So I'm very pleased to welcome Dr. Akhil Kulkarni to our ISPAE ACES Pediatric Endocrinology teaching meeting. He is a radiologist and is a professor of radiology working at Davangere Medical College.
Yes, sir. Yes, Davangere Medical College.
And he has had several publications in renowned national and international journals. He is particularly interested in fetal musculoskeletal radiology and has a special interest in skeletal dysplasia. It is rare to have radiologists who can read X-rays nowadays. So it's a pleasure to have you, Dr. Akhil, and I'm sure that everybody will be looking forward to listening to you to help with the differential diagnosis of skeletal dysplasia. Over to you, Dr. Akhil.
Just a minute, Professor Mughal has joined, so we'll just welcome Dr. Mughal. Very good morning, sir.
Good morning, Dr. Mughal. You have joined very early. It's very early in England.
Very early.
I was asked. No, I had a WhatsApp message that I should join. So.
Thank you so much.
Thank you for joining early.
I usually obey orders, so I sort of promptly joined. And I've enjoyed sort of listening to the previous talk. Very good case presentation, and I look forward to hearing about the next presentation, which of course, as Ganesh has said, can be very challenging. I think radiological assessment of skeletal dysplasia is very challenging, and in the UK we only have 2 radiologists who I would regard as experts in this area. So very rare people who can look at skeletal dysplasia. So I think I'll stop at this stage and look forward to listening.
Thank you, sir.
Dr. Akhil,
thank you, Dr.
You can start sharing the screen.
Yes, sir. So are my slides visible, sir? Am I audible?
Yes.
Okay. So thank you, sir, for the kind introduction. And thank you, Shaila madam and the organizers for giving me an opportunity to talk in front of such an learned audience. So being a radiologist, I'll be mainly talking about a radiological approach to the skeletal dysplasias. Yes. So, yes. So whenever we think about skeletal dysplasias, most of the resident and most of the consultant have this feeling. And today I am also having the same feeling because I've been asked to cover skeletal dysplasia in 20 to 25 minutes. So I'll try to do my best and try to simplify the topic for the radiological approach. So skeletal dysplasias are the heterogeneous group of disorders affecting the growth and development of bones and cartilage, often leading to disproportionate shortening of the limbs and spine. It has an incidence of 1 in 5,000 live birth, and there have been more than 450 types of skeletal dysplasias have been primarily classified based on their clinical, radiological, and molecular criteria. Now going back to the history, skeletal dysplasias were thought to either present with short limb dwarfism or short trunk dwarfism. So sooner the experts in various fields started to realize that most of these osteochondral dysplasias were not falling into these criteria. So hence they decided to form the nosology and classifications of these genetic skeletal disorders. So the first ever nosology of these bone disorders was published in 1970. Then thereafterwards, they kept on refining these classifications. And here we have the latest revision, which is done in 2019. This is a very beautiful article published in American Journal of Medical Genetics. That is 2019 revisions. So according to the 2019 revision, which is nothing but the 10th revision. So according to this, we have 461 types of skeletal dysplasias, and which are classified into 42 groups based on their clinical, radiological, and molecular phenotypes. So among these 461 types of dysplasias, we have pathogenic genes identified for 425 types of skeletal dysplasias, accounting for 92% of these skeletal dysplasias having pathogenic genes identified for them. So some of the highlights of this revision include they follow the approach of genotype first and phenotype later in unknown skeletal dysplasias. So some groups like group 18 has been now termed as bent bone dysplasia instead of campylomelic dysplasias. Group 19 changed from slender bone dysplasias to primordial dwarfism and slender bone group. New entities have been identified to spondyloepimetaphyseal dysplasia group, that is group 13. And some of the examples of these group include mainly based on their pathogenic gene and clinico-radiological findings, that is chondrodysplasia group, type 2 collagen group, ciliopathies with skeletal involvement, craniosynostosis syndromes, osteogenesis imperfecta and decreased bone density group, and abnormal mineralization group. So I would like to skip this slide because you are the subject experts in the clinical evaluation. And when I heard the last speaker talking about the clinical examination, very thorough, meticulous clinical examination she had done. So I would like to skip this slide. So I will be talking mainly on the radiological approach. So complete genetic skeletal survey remains the mainstay in a suspected case of skeletal dysplasia. And it is the only area where conventional radiography plays an important role in this advanced cross-sectional imaging that of CT and MRI. So when do we do the skeletal survey? So skeletal survey is done in case of disproportionate short stature. So most of these skeletal dysplasias have disproportionate short stature. Some exceptions include osteogenesis imperfecta and some sclerosing bone dysplasias. So when we have a proportionate short stature, the complete skeletal survey is not mandatory. It can be taken a call based on the clinical criteria. A simple AP radiograph of the hand to assess the bone age should suffice the purpose. Now, what does the skeletal survey include? So skeletal survey includes AP and lateral radiograph of the skull, AP and lateral radiograph of the spine, preferably involving the thoracolumbar spine, chest AP, pelvis AP, and PA view of hands and wrist, and AP view of the long bones. So coming to the radiological approach. So what do we look when we have a suspected case of skeletal dysplasia? One, look for the bone mineralization, involvement of the axial skeleton, involvement of the appendicular skeleton, and any growth delay or any other associated abnormalities are there. We need to make a note of it because it gives a clue towards some of the skeletal dysplasias. Now coming to the bone mineralization. So here we have an radiograph, AP radiograph of a child where we are seeing normal density of the bone, normal cortical thickening, normal corticomedullary differentiation. So another radiograph of a child of this similar age, we are seeing that there is bowing of the long bones, pencil thin cortex, and diffuse decrease in the bone density. And this is a case of decreased bone density dysplasias, that is the prototype being osteogenesis imperfecta. And these are zebra lines post bisphosphonate therapy. I think all of you are much aware of these things. So another radiograph of a child of similar age where we are seeing diffuse increase in the bone density and there is cortical thickening with loss of corticomedullary differentiation. Yes, we are looking at sclerosing bone dysplasias. So we need to assess the density, whether it is of normal density or it is of decreased density or it is of increased density. Now coming to the axial skeleton involvement. So in the axial skeleton, let's see what we need to assess in skull. So in pediatric age group, we should be aware of things. In the radiographical appearance of the bones are different from the adults. So awareness of these things is very important. So in a given skull radiograph, what do we assess? Again, we assess the density, size of the skull, shape, and the cella, which is the favorite of most of the endocrinologists present here. So here we have lateral and AP radiograph of the skull, where we are seeing the normal calvarial thickening, normal density of the bone, normal sutures, This is coronal, this is sagittal suture, normal orbits, and normal shape of the sella. So these things has to be evaluated whenever we have a suspected case of skeletal dysplasias. So here we have a lateral radiograph of the skull, wherein we are seeing almost no ossification of the calvarium, and there is diffuse decrease in the bone density. Yes, this is a case of hypophosphatasia. Similarly, we have AP and lateral radiograph of skull radiograph of a child, wherein we are seeing decreased bone density with multiple complex fracture. These are all the fracture lines. So yes, we are looking at osteogenesis imperfecta. Now, we saw decreased bone density in the skull. Similarly, we see for the any increase in the bone density. So increase in the bone density can be generalized or it can be localized. So whenever here in the lateral radiograph, we are seeing diffuse increase in the bone density, it is a prototype for sclerosing bone dysplasia, that is osteopetrosis. Now here, there is an increase in the bone density, but it is localized. So we are seeing the increase in the bone density in the skull base and in the frontal bones. Yes, this is frontometaphyseal dysplasias. So just to summarize, the densities of the skull density can be decreased or increased. Decreased density we see with osteogenesis imperfecta and their subtypes, and increased density can be generalized or localized. Generalized we see with sclerosing bone dysplasias, localized we see with frontometaphyseal dysplasia and craniometaphyseal dysplasia. Now, coming to the assessment of the size of the skull. So this is usually better done clinically, whether there is a microcephalic head or a macrocephalic head, it's better done clinically. But for the completion's sake, here we have a microcephalic skull with multiple plate-like calcifications in the intracranium. Yes, this is a case of pseudo-torch syndrome, which mimics a torch syndrome. There are some characteristic radiological findings and clinical findings which helps us to differentiate between those two entities. So here we have a macrocephalic skull with stenosis of the skull base. Yes, we are looking at achondroplasias. Now coming to the abnormal head shape. So abnormal head shape is mainly due to the sutural synostosis. So here we have a lateral radiograph of a child wherein there is scaphocephaly, secondary to the premature closure of the sagittal sutures, and we are having bicoronal synostosis, and another radiograph where we are seeing abnormal shape of the head due to the unilateral coronal synostosis termed as plagiocephaly. Now, this is the favorite of most of our radiology residents. So cloverleaf shaped skull we usually see with the thanatophoric dysplasias. Now, evaluation of the sella, it is important, but sella usually do not have any primary changes secondary to the skeletal dysplasia. So usually they are secondary, and secondary due to the increased intracranial pressure. In mucopolysaccharidosis, we usually have this J-shaped sella along with some characteristic other radiological findings, which helps us to arrive at a diagnosis. Now, Wormian bones, yes, Wormian bones are nothing but these are the islands of bones which we see in the sutures, and they are seen in many skeletal dysplasias like osteogenesis imperfecta, cleidocranial dysostosis, and so on. Now, the evaluation of the spine is very, very important in skeletal dysplasias. So before going to the proper evaluation, we need to know the normal appearances, how a normal spine looks in a pre-pubertal age group, in an pre-adolescent, how do they look? So here we have three radiographs, that is lateral and AP radiograph of dorsolumbar spine, where we are seeing a globular shape of the vertebral bodies, central spit-like lucency here, and anterior clefting. These things should not be confused for any abnormality. The globular shape of the vertebral body is common appearance, common radiological appearance, what we see in a prepubertal age group, and this lucent line, which mimics a spina bifida, is nothing but an unossified spinous process, and this anterior clefting is a normal appearance. So here, just for the comparison, we have a radiograph of an adolescent, AP and lateral view, where we are almost seeing an appearances of the spine similar to the adult. So here we are not seeing that lucent line, the central tufting is not there, and the globular shape of the vertebral bodies is not seen. So some skeletal dysplasias have very classical spinal abnormalities. So here we have a case of achondroplasia, where we are seeing varying degrees of platyspondyly, the reduced interpedicular distance, and posterior scalloping, which can be seen with achondroplasias. So similarly, we have platyspondyly with anterior tongue-like projection, often mimicking an mucopolysaccharidosis. So mucopolysaccharidosis, we have beaking. Here we have central tongue-like projection, which is seen with pseudoachondroplasia. This is a classical findings of pseudoachondroplasia along with other radiological signs. So similarly, we have spinal abnormalities with other epiphyseal abnormalities termed as spondyloepiphyseal dysplasia, and there are two varieties there, congenita and tarda variety. And some classical features of this congenita variety include varying degrees of platyspondyly and isospondyly, that is variation in the size of the vertebral body. So here we can see that the L5 vertebra is smaller when compared to the other vertebral bodies, and there is central beaking, what we see in the cervical spine, and lack of ossification centers of the femoral head, often mimicking a DDH. So these are all some of the classical signs of spondyloepiphyseal dysplasia congenita variety. And here we have spondyloepiphyseal dysplasia tarda variety. So here the classical imaging findings include, we have varying degrees of platyspondyly. The degree of platyspondyly is usually less compared to the congenita variety. And we have classical posterior hump, that is posterior 2/3 of the vertebral body will show hump. And this is very typical of this tarda variety, along with the changes seen in the epiphysis. So here we have epiphyseal changes with some secondary changes, secondary osteoarthritic changes in the hip joint. So if we have spinal abnormality with metaphyseal abnormalities, think about spondylometaphyseal dysplasias, and other skeletal dysplasias like osteogenesis imperfecta can have this fish mouth appearance of the vertebra, that is biconvex shape of the intervertebral discs with shepherd crook deformity secondary to the fractures and the bowing of the long bones. And we can have the sandwich vertebrae in the vertebral bodies, and Erlenmeyer-Flash deformity in case of this osteopetrosis. So similarly, we have vertebral anomalies with rib anomalies. Think about costovertebral dysostosis. Here we have varying degrees of vertebral anomalies ranging from hemivertebra to butterfly vertebrae, and we are having absent ribs and deformed ribs. Think about costovertebral dysostosis. Punctate calcifications along the spine and in the pelvis. Think about chondrodysplasia punctata. So this is an algorithmic approach for the spine in a suspected case of skeletal dysplasias. Now coming to the chest, we have very classical findings in some of the chest disorders, skeletal dysplasias with chest manifestation. So we are having this short rib with postaxial polydactyly, the case of short rib polydactyly syndrome. And we have June's thoracic dystrophy, where we have classical bell-shaped thorax, and usually such children have complications related to the pulmonary agenesis, pulmonary hypoplasia. Now coming to the appendicular skeleton. So involvement of the appendicular skeleton is an assessment of the appendicular skeleton is very important. We need to know whether there is a rhizomelic shortening, mesomelic, or severe micromelic. And we had an extensive discussion about the clinical parameters. Unfortunately, we don't have any radiological parameters to differentiate the one. It's just eyeballing. And yes, so there are some prototypes for these limb shortenings, and they can always come with combination, that is they can have mesomelic and acromelic shortening, rhizomesomelic shortening, various combination can come. And if the entire limb is shortened, we call it as micromelic shortenings. Now coming to the assessment of the epiphysis. So epiphysis in a suspected case of skeletal dysplasias, what are all the abnormalities what we can have in an epiphysis? One, we can have delayed ossification of these epiphysis. We can have thinned out and fragmented epiphysis, as we can see here, all fragmented epiphysis. We can have flattened and squared off epiphysis, and delayed and irregular secondary ossification centers. So these are all some of the epiphyseal changes what we need to see in a suspected case of skeletal dysplasias. So similarly, metaphyseal changes in a suspected metaphyseal dysplasias include, we can have metaphyseal flaring, cortical bone thinning, genu-valgum deformity, and an Erlin-Meyer flash deformity of the long bones. So diaphyseal changes include the cortical thickening at the diaphysis, irregular endosteal sclerosing, sparing of the epi and metaphyseal regions. So pelvis, yes, abnormal shape of the pelvis helps us arriving at some of the diagnosis. Like we have here, we have a champagne glass appearance of the pelvis, that is squared off iliac bones, narrow pelvic inlet, giving a classical champagne glass appearance. And I'm sure most of you are aware what I'm talking about. We are talking about achondroplasia. Now, similarly, we have hypoplasia of the femur with dysmorphic facial features. Yes, we are looking at femoral hypoplasia, unusual faces syndrome. So coming to the some common skeletal dysplasias, yes, not all skeletal dysplasias will have mental retardation. Yes, so coming to the achondroplasias, this is the most common non-lethal skeletal dysplasia inherited as an autosomal dominant fashion. And we have various radiological appearances like rhizomelic shortening of the long bones, metaphyseal abnormalities, trident hand, champagne glass appearance of the pelvis, macrocephalic head, and skull base stenosis, and lumbar canal stenosis. All are these some classical radiological findings what we need to be aware of in a case of achondroplasias. So similarly, pseudoachondroplasia, they belong to group 10, multiple epiphyseal dysplasia and pseudoachondroplasia group, inherited as an autosomal dominant disorder. And we classical radiological finding already told to you, that is central tongue-like projection of the vertebral body with epi and metaphyseal changes. Some classical differentiating features between pseudoachondroplasia and achondroplasias, that is, skull is usually normal in pseudoachondroplasias. They have platyspondyly, interpedicular distance is normal, epiphysis and metaphysis usually abnormal, and they lack these classical signs like trident hand and champagne glass appearance of the pelvis. So osteopetrosis, yes, it is a prototype for sclerosing bone dysplasias. We already mentioned about the classical radiological findings of osteopetrosis, that is sandwich vertebra, diffuse increase in the bone density, Erlin-Meyer flash deformity. So we have a diagnostic dilemma when we are evaluating a sclerosing bone dysplasias radiologically. So the most common radiological dilemma what we have is between osteopetrosis and pycnodysostoses. So these pycnodysostoses is differentiated from osteopetrosis by some classical radiological findings like hypoplasia of the mandible and distal acroosteolysis, and usually the clavicle can also have hypoplasia, that is medial end of the clavicles can have hypoplasia. So these findings helps us to differentiate between osteopetrosis. So osteogenesis imperfecta, yes, it is based on their clinical and disease severity. They have been classified into various types. They can have extraskeletal manifestations like blue sclera, dentagerous imperfecta, and deafness. So yes, the classical radiological triad is include diffuse osteopenia, pencil thin cortex, and varying degrees of fractures in different ages. So cleidocranial dysplasia, yes, so they have a, clinical, most of them, they would have, you can make this diagnosis clinically. They'll have short stature and the approximation of the shoulder. These classical clinical findings helps us to arrive at a diagnosis. But some radiological findings include, they have agenesis or hypoplasia of the clavicle, wide frontanelle, Wormian bones, and very typical presence of accessory secondary epiphysis in the second metacarpal bone. is a very hallmark of this cleidocranial dysplasias. So mucopolysaccharidosis, the prototypes could be hurlers and hunters. They have classical radiological appearance like macrocephalic skull, J-shaped cella, paddle or oar-shaped ribs, bullet-shaped metacarpals, and varying degrees of platyspondyly and beaking, in anterior inferior beaking, which we see with Moricus syndrome. Yes, this is the beaking what we see with mucopolysaccharidosis syndrome, and the degree of platyspondyly is much severe when compared to these spondyloepiphyseal dysplasias. So spondyloepiphyseal dysplasias, I've already told you, they can be congenital variety, or it could be a tarda variety. Yes. So this is classical findings which I've already highlighted in the previous slides. I'll skip this. Yes, to conclude, osteochondral dysplasias are rare. Appropriate algorithmic clinical and radiological approach helps us to group them in several ways for further evaluation. Accurate molecular diagnosis of skeletal dysplasias is more important in this era of up-to-date genetic counseling. Prenatal, pre-implantation genetic diagnosis, and hopefully molecular targeted therapeutics in the future. Hopefully I've tried to simplify, like as Bahubali training, teaching the art of archery to Devasena. Thank you one and all for patient listening.
Thank you so much, Dr. Akhil. I think it was probably even simpler than, because Devasena herself was quite talented. So you really presented the teaching in a very systematic manner, and something which even a basic trainee pediatric endocrinologist can grasp and understand about how to approach, because right from the confusion starts right from which X-rays to order, basically. So for example, so that is my first question to you, that often we kind of tend to budget on the X-rays, that probably most of us are aware that skeletal survey doesn't give a huge amount of radiation per se.
Yes, sir.
But what do you suggest, that once we suspect that there's a clear-cut skeletal dysplasia, we should just simply go for all the X-rays that you mentioned? Or...
Yes, sir. A complete genetic skeletal survey is must for evaluation of suspected skeletal dysplasias, because we need to evaluate the involvement of these appendicular skeleton and axial skeletons, because those things helps us in differentiating. So, for example, today the first speaker was talking about dysplasia. The moment I saw the clinical picture, I thought about spondyloepiphyseal dysplasia tarda variety. But based on the classical radiological finding, like she said, that there was a central clefting which was a characteristic. So in tarda variety, we have this posterior bulge in the posterior 2/3 of the vertebral body. So those subtle changes help us in arriving at the diagnosis.
Yeah. So there are a few questions in the chat box.
Yes,
so one of the thing is about how do you define platyspondyly? Like, is there any criteria, or you just go by your visual?
Sir, it is basically on eyeballing. So we see if in an radiograph, if we see there is a flattening of the vertebral bodies. So flattening of the vertebral bodies are termed as a platyspondyly, and we have varying degrees. So basically on eyeballing, so whether it is a severe degree platyspondyly or a milder degree of platyspondyly, we can say that.
Talking of epiphyseal irregularities, there's a question by Dr. Divya asking, when would you consider epiphyseal irregularities to be significant? Is there, like, if you have, let us say, 1 or 2 bones looking a little abnormal, versus obviously if there are all the bones are looking abnormal, you would, but is there any like definition of this particular thing?
Epiphyseal irregularity in a child's X-ray, it should be considered. Sir, the epiphyseal abnormality is one is when we assess the bone age. So if there is delayed in the ossification center there, so there has to be some cause for the delay in the bone age. And whenever we have an epiphyseal presence of these epiphyses with these changes, should be considered in any part, especially the hand radiographs. If we see the changes, if they are striking, we should consider the epiphyseal abnormalities.
Yeah. You used the terminology genetic skeletal survey, but I think you just meant skeletal, the X-rays.
Yeah, skeletal survey, yes.
Yeah. Dr. Sudha has asked, Dr. Sudha from Mumbai, she's asked a question. Conditions like osteopetrorickets, both sclerosis as well as undermineralization would be seen. Any comments on any such entities, like any? Where you have a combination of sclerotic findings and undermineralization.
So, sir, usually osteopetrosis is more generalized, and involvement of the the bones is extensive. So, yeah, I mean the radiological findings like cortical thickening and the deformities, like this Erlen-Meyer-Flass deformity of the long bones, all those things are much evident in osteopetrosis dysplasias.
Yeah. So thank you. I hope that at least till now, what has happened is that I used to order some X-rays, and then my genetic colleague used to exactly ask the X-ray which I have not done in that particular patient. So hopefully that will not happen now, and hopefully we will also be able to kind of have some sort of a idea of what particular type of skeletal dysplasia it is. I think it's just a matter of practice of starting somewhere and then going on seeing these X-rays. Thank you so very much from all of us for joining today on a Sunday morning and teaching us. And as you can see in the comments, that your talk has been highly appreciated by everybody. Thank you so much, Dr.
Thank you, sir. Thank you, everybody.
Hope to see you again.
Sure, sir. Thank you very much, sir.
Over to you, Dr. Divya. Thank you, Dr. Divya and Dr. Shaila, for inviting me as a moderator.
Thank you, Dr. Akhil, Dr. Ganesh, and Dr. Swati for the wonderful academic excursion in the first part. Thank you all very much, and we'll be moving to the second part of the session. I'll invite Shaila ma'am to invite the presenter and speaker. Thank you.
Yeah, good morning again. So the second case will be discussed by Dr. Lakshmi Harshita. She is second year DNB candidate from Sri Ramchandra Institute of Higher Education and Research from Chennai, and Dr. Divya Lakshmi is been her guide. And to discuss this case, we have Dr. Sirisha. Again, Sirisha is very well known in our pediatric endocrine fraternity. She is consultant pediatric and adolescent endocrinologist at Rainbow Children's Hospital, Hyderabad. She's been a core committee member of IDL, that is our diabetes education and learning course, what we are doing for type 1 diabetes, that is educating the diabetes nurses, diabetes educators, and also now we are going to have the third batch for educating the doctors regarding the type 1 diabetes. And then Dr. Mughal will be for the next talk. Dr. Mughal is my very good senior friend, and he is consultant in pediatric bone disease at Royal Manchester Children's Hospital and a clinical professor in Child Health University of Manchester. Anytime, any problem, you please mail him. He will answer back, reply back to your mails within 24 to 48 hours. So all our difficult cases we do discuss with Dr. Mughal, and he's been very helpful. Thank you very much, Dr. Mughal, for joining us today. And now over to Dr. Sirisha and Dr. Harshita, please.
Thank you, Dr. Shaila. Thank you very much for the kind introduction and inviting me to be moderating this session. And Harshita had taken wonderful efforts in following up the case and gathering all the follow-up data and everything for this particular child. So we will have the clinical presentation just like the previous session. We'll have some discussion after the history and the clinical examination, and then we will move forward to the evaluation and further discussion. Harshita, if you could share your screen, please.
Yes, ma'am. Is my screen visible, ma'am?
Yes, Harshita. go to the first, yeah.
Good morning, ma'am. This is an interesting case of rickets presented by Dr. Harshita, guided by Dr. Divyalakshmi, and my moderator is Dr. Sirisha Kusuma. Coming to history, the chief complaints are that a 1 year, 8-month-old male child brought with complaint of poor height gain and abnormal curvature and bowing of both the legs noted since past 3 months. So, detailed explanation for past 3 months, child was observed to be short compared to peers, bowing of legs, walks only with support with a wide-based gait, cannot walk beyond few steps, parents not able to make a progression of any bony changes, but mother noticed widening of the wrist for the past 3 months. Dentition, first teeth erupted at 1 year of age. Currently, all incisions are erupted. There is no hair, nail, or skin changes noted. There was history of poor weight gain and poor outgrowing of clothes and shoes observed. Coming to history of any systemic illnesses, there is no polyuria or polydipsia, no poor oral intake or persistent vomitings, no history of any recurrent illnesses, and no history suggestive of hypothyroidism. Birth history, antenatal wise, it was an ovulation induction conception. Mother was booked, immunized accordingly. History of oligohydramnios and hypertension during the 3rd trimester was present. Baby delivered by emergency LSS at 31 weeks of gestational age. Cried at birth, had a birth weight of 1.35 kgs, low birth weight, extremely low birth weight, and length of 39 centimeters. Postnatal, there is history of NICU admission, and significant history was that NEC at 1 week of 1 week after delivery, ileostomy surgical procedure done, and ileostomy closure done at 5 months of age. Baby was on breastfeed and neocate feeds, continued till 7 months of age. Just started on complementary feeds. There is no history of any cow milk or formula feeds being given. Not started on any calcium or vitamin supplementations. He was started on calcium supplementation for past 3 months at 17 mg per kg per day calcium and 8.5 mg per kg per day phosphorus, and vitamin D 100 international units per day being given in the form of calcimax syrup. Developmental history, there was gross motor delay observed with a developmental age of 10 to 12 months. Crawls mostly, currently walks with support for a few steps. Otherwise, speech and social milestones were normal. Examination findings are that on assessment, anthropometry, weight was falling between -2 to -3 z-score, and the height was assessed to be falling less than -3 z-score. On upper segment to lower segment ratio assessment, it was 1.43, which was indicating short limbs. Examination findings, head-to-toe examination was suggestive of frontal bossing with wide open fontanelle, and chest examination showed pectus carinatum, rachitic rosary, bowing of the forearms, widening of the wrist, and on lower limb examination, genu varum and genu recurvatum were present, and pes planus is seen. Along with double malleoli, and no goiter suggestive of any thyroid abnormalities, and all these features altogether were suggestive of vitamin D deficiency, probably vitamin D deficiency, and our diagnosis pointing towards rickets. SMR was prepubertal, and systemic examination, no abnormality was detected.
We'll go back. We'll just stop here and go back.
Yes, ma'am.
Yeah, so as you rightly mentioned, all these changes are suggestive of clinical rickets, like they look like clinically signs of rickets, all the signs of rickets. Epiphyseal changes predominantly, end of the long bones and costochondral junctions. So growth plate changes predominantly, isn't it? So here we cannot for sure say it is vitamin D deficiency. We can only say it's one of the differential diagnoses. Given the epidemiological situation, is most probably the first thing that we need to think would be vitamin D deficiency. We can say it's a clinical rickets basically. So it could be anything. So if we can go back in the history, there are so many things that are actually relevant and very, very important that can actually give us the clue of what kind of rickets it could be, even before going to further investigations, isn't it?
Yes, please.
Yeah. So if you look at this, the natal and postnatal history is extremely important in this young child. Any child under 1 to 2 years of age, young child presenting with rickets, So can you highlight what are the things that would point us towards the possibility of nutritional rickets rather than other causes of rickets?
Yes, ma'am. Preterm delivery, child being low birth weight, and history of any NEC and bowel resection being done, which affects the absorption in the child, and feeds being completely on breastfeeding and neocate feeds, not being supplemented with any calcium or vitamin D supplementations, and no other formula cow milk intake which was given. These are all the pointers towards nutritional deficiencies that can be observed in the child, ma'am.
Yeah, the predominant thing is a preterm premature baby with a low birth weight, not supplemented with a high mineral formula, or we don't know if the baby was supplemented with human milk fortifier. It was just purely breastfeeding. We don't have that history. And we've seen that baby was also given neocate feeds, and there are few cases where elemental formula can cause poor, can be associated with poor phosphorus absorption, and that can lead to hypophosphatemia, and that can aggravate the metabolic bone disease. And of course, we have history of NEC, and so we don't actually know whether they have screened for metabolic bone disease, typically which kind of happens after the discharge from NICU, maybe at 12 to 14 weeks of postnatal age. So if that particular window period is missed and nobody screens for metabolic bone disease, that deficit kind of carries on, and postnatal diet definitely worsens that. Postnatal dietary deficiency would definitely worsen that. And we've seen that only last 3 months baby was supplemented with a very, very small dose of vitamin D, in addition to a small calcium supplement. So this is a predominant history actually. Yeah, we can move forward. Harshita.
Yes. So on radiology, coming to investigations, X-ray findings are that there is increased distance between metaphysis and growth plate noted. Generalized osteopenia of bones is seen, and cupping, fraying, and splaying is observed in ulnar, radius, metacarpal, and also phalangeal bones. And coming to
back and give some time to have a look at the X-ray.
Yes, yes.
So if any doubts, please type in the chat box. So we can see significant changes in the epiphyseal metaphyseal junction, the growth plate, the poor mineralization of the growth plate. Typically, I call it as a rat eaten appearance, and very, very thin cortices as well. So Satyakala asks, is it specifically neocate or any elemental formula causing low phosphate? The low phosphate is usually, it's been reported only with the neocate formula for some reason. I think the type of the phosphorus that's been supplemented in the neocate could be the reason. We can only speculate that. There are no RCTs to prove that, but it's been reported only with neocate. So yeah, we can move.
Yes. And coming to serological parameters, serum calcium was parameters were suggestive of hypocalcemia, for hypophosphatemia, alkaline phosphatase being elevated, deficiency, vitamin D deficiency is noted, which was 6 nanograms per ml, and parathyroid levels being elevated. Other serological parameters, thyroid and creatinine and renal TRP were found to be within normal range. So
we'll just go back once,
yes,
Harshita.
Yes.
Yeah. So can you do you know why the parathyroid hormone is high?
Yes, ma'am. This is the reactive hyperparathyroidism that occurs, ma'am. Secondary hyperparathyroidism caused due to calcium deficiency, which is due to the vitamin D deficiency that is happening.
Yeah, absolutely. The severity of the secondary hyperparathyroidism indicates the severity of the whole body calcium deficiency actually. Sometimes serum calcium can be normal, but we need to remember that that is at the expense of hyperparathyroidism, drawing the calcium from the bones, unless we correlate our bone density with serum calcium and PTH, we cannot actually know the calcium adequacy. So we never take our serum calcium as a indicator of whole body calcium adequacy. It's always the parathyroid hormone and bone density.
Yes.
Yeah.
So our diagnosis was vitamin D deficiency rickets with underweight and short stature. And as treatment, child was started on polycalciferol sachet, 60,000 international units, half sachet once a week for next 6 weeks. Syrup Calcimax supplementation, 5 ml TDS, which was giving 53 mg per kg per day of calcium, 26.5 mg per kg per day of phosphorus, and 300 international units of vitamin D supplemented to the child. So on follow-up assessment, at 3 months, child was walking better with support, more alert and communicating. There was provisional zone of calcification seen on radiological findings. And polycalciferol continued for next 6 weeks along with calcium supplementation in view of persistent elevated alkaline phosphate, which will be represented in following slides, ma'am. So on follow-up, there is improvement in serum calcium and serum phosphorus levels observed. Normalizing alkaline phosphate levels are seen, and vitamin D levels are maintained at a count above greater than 70 international units, and parathyroid hormone levels are also normalizing. And child was continued with the follow-up treatment. Child was continued on polycalciferol and calcimax supplementations.
Yeah.
So at 1 year of follow-up, child walks without support. The genu varum and genu recurvatum deformities are still persistent, but there is radiologically improvement in mineralization is seen. And anthropometry assessment wise, there was improvement in weight now falling between 0 to -2 z-score, and height still falling between -2 to -3 z-score even after improvement. That could be due to the bony deformity still persistent. So to define vitamin D deficiency, vitamin D assessment is done through fasting LC-MC method and LC-UV method, and it is classified as sufficient if it's greater than 20 nanograms per ml, and 12 to 20 as insufficiency, and deficiency if it is less than 12, which is seen in our case, and if it's more than 100 nanograms per ml is considered as toxicity as per recent guidelines of Indian Academy of Pediatrics. So the children who are at risk of vitamin D deficiency are with periods of rapid growth, preterm, infancy, and adolescence. Secondary infections such as chronic kidney disease, malabsorptions, inflammatory bowel disease, disorders with extensive cutaneous involvement, cystic fibrosis, obesity, and granulomatous disorders such as TB and sarcoidosis, and other medications such as anti-epileptics, steroid medications, and rifampicin, etc.
We'll just go back to the slide. Just a couple of comments. So regarding the medication, do you know why they can lead to vitamin D deficiency?
By medications involved with absorption, they cause absorption defect, ma'am.
Yeah, that's okay. Steroids can affect calcium absorption, but anti-epileptics, certain antifungals, they can, they're stimulators of P450, cytochrome P450, and they can enhance the vitamin D metabolism and elimination from the liver. So we may need to, whoever are on those medications need regular supplementation. And most of the neurologists, if you see, they do put them on vitamin D as well, along with the anti-epileptics most of the times.
Yes.
And granulomatous disorders, if I remember, more often they do cause hypercalcemia, and they can stimulate 1-alpha hydroxylase, which causes more production of active vitamin D, the 125 vitamin D, which can cause hypercalcemia. But I don't actually know how they can result, so I need to look into that. Yeah, the most common things that we do see is the first box that you mentioned, isn't it? The preterm infants and periods of rapid growth. If I can take a minute to make this comment. I think most of my colleagues would agree with me when I say that we are seeing more cases of adolescent rickets in the last 2 to 3 years, especially after the COVID lockdown and COVID restrictions. At least I haven't seen adolescent rickets before that. I've seen only in younger children. So adolescents coming with severe osteopenia and hypocalcemia and even tetany, to that extent that it's causing tetany and spasms purely because of nutritional deficiency. Here it was not only vitamin D deficiency, it was a combination of significant calcium deficiency, dietary calcium deficiency, as well as vitamin D deficiency. Because these days we are seeing a lot of food fads where they're stopping drinking milk, thinking that there's so many hormones in milk and they don't have an alternative calcium source. So we can move.
So as per Indian Academy of Pediatrics revised guidelines on prevention and treatment of vitamin D deficiency, the treatment guidelines are that if a child is less than 6 months, daily dose of 200 international units is being given. There is no alternative regimen available and continued on maintenance dose of 400 international units per day, along with calcium supplementation of 50 to 75 mg per kg per day, with a maximum dose can be given up to 500 mg per day. So if for infants between 6 months to 12 months, 200 international units per day daily dose or an equivalent of 200 international units per day on a monthly or weekly basis can be given, with daily maintenance dose of 400 international units and calcium supplementation being continued at 50 to 75 mg per kg per day. If a child is greater than 12 months, the daily requirement is 3,000 international units, or an alternative regimen available is that 60,000 international units fortnightly every 2 weeks, which is given for the next 5 doses, and 600 international units per day maintenance dose is being given. So optimum duration of maintenance vitamin D therapy is not known at present, and massive doses TOS therapy is currently not recommended. Monitoring the treatment, there is no consensus guidelines for the monitoring of vitamin D, monitoring the treatment for vitamin D. So as per our monitoring, X-rays at every 4 weeks and at 12 weeks of therapy, biochemical analysis to be conducted at 12 weeks of therapy, assessing the serum calcium, phosphate, alkaline phosphate, and vitamin D levels. And if poor response by 12 weeks of therapy is seen, then look for non-nutritional rickets, RTA, and vitamin D deficiency ricket, vitamin D dependent rickets. So for this, investigations followed will be with measurement of 25 OHT, 125 OHT, intact parathyroid hormone, urine analysis, LFT, serum creatinine, urine calcium creatinine ratio to be assessed. On follow-up, periodical biochemical monitoring for optimum levels, and 25 OHT levels if are increasing between 100 nanograms per ml, a child to be monitored for hypercalcemia and hypercalciuria. So what are the corrections that can be noticed in the child? Serological improvement like serum phosphorus occurs within 96 hours, serum calcium within 1 week, alkaline phosphate level is decreased, and radiological improvements are seen between 1 month, 3 to 4 weeks, and physical deformities take months to years to get corrected. So radiological reevaluation to be done at 4 to 6 weeks, continue treatment for at least 4 to 6 months till complete radiological healing. And coming to clinical assessment, motor milestones improvement observed within 2 to 3 weeks. Most deformities correct with growth, and if severe deformity and not corrected, orthopedic correction after healing is required. So coming to key message, all infants, especially premature and exclusively breastfed infants, are at risk of vitamin D deficiency. Preventive dose of vitamin D, that is 400 international units, to be introduced in all infants on exclusive breastfeeding. Recent update on IAP guidelines for treatment of vitamin D deficiency is available, and prolonged monitoring of children with nutritional rickets is necessary. Thank you.
Thank you, Harshita. That's a very, very clear presentation. Thank you very much. If you have any questions, you can take it in the chat box. So, so Varsha was asking 125 vitamin D levels at that point, but we did not, I think, to the investigations, if you go to the investigation slide, when we have noticed PTH, at that point, our vitamin D levels are low. So we don't do 125 vitamin D without correcting our vitamin D. So we correct the vitamin D levels first and then reevaluate. Still, we are not seeing any improvement. Then we would look for other rarer forms of rickets by doing the 125 vitamin D. So daily versus intermittent vitamin D dosing. Harshita, would you like to elaborate whether we should give daily vitamin D or intermittent? Or should I take that?
Yes, ma'am. Daily vitamin D, if proper adherence to treatment and daily vitamin D regimen can be given, that would be the best treatment to be given, ma'am. If with poor compliance to treatment and if majorly lack of compliance to treatment and poor oral intake, then weekly regimens are better preferred, ma'am.
Yeah, that's a very good point. If you can go to that slide of recommendations, these days, most of us do follow daily replacement under 1 year, especially. I would even consider under 2 years also, if it is a very small child. But if compliance issues are predominant, we should ensure that the medicine, the dose has gone in. So if compliance is a real big issue, we would go with weekly regime, even in younger children. I would say that as a personal opinion, but this is the recommendations from the latest recommendations from the IAP, where they do suggest only daily under 6 months, daily versus weekly or monthly beyond 6 months. And this here, I think the last box is most important, the calcium replacement. And we cannot forget that if we just give vitamin D, we are not going to, we may actually precipitate severe hypocalcemia and symptomatic hypocalcemia in severe rickets if we do not supplement good dose of calcium. So we should be supplementing good dose of calcium till the bone density recovers completely, and then we can switch to dietary supplementation. Yes. So any more? Dr. Sudhara ma'am says, increased use of turmeric in the milk and excessive associated with excessive weight gain. Yeah, I would leave it to the experts to comment, because I don't know actually if turmeric, whether it would decrease the calcium absorption and how it would decrease the calcium absorption. That is something that definitely needs to be considered or looked into, maybe, I guess.
She's saying it has more phosphorus. Turmeric has
the turmeric. Okay.
Yes.
Oh, okay. I don't know that actually.
Yeah, I was also not aware. And I don't know if Dr. Mughal would know about turmeric also, because they wouldn't use in England.
Okay.
Unless in all houses.
Well, I take turmeric as a supplement every day, and of course we use it in our cooking. But I didn't know about phosphate, but I think phosphate is a good point. One of the things is that if you give pharmacological doses of phosphate, you get transient drop in calcium, and that will trigger a PTH response, and PTH will of course act on the kidneys and cause a loss of phosphate. And as I will show in my lecture, that serum phosphate is an important in the pathogenesis of rickets. So that's very interesting. Perhaps I should stop taking my phosphate supplement, turmeric supplements.
So just, I think one more question in the chat box. Does duration of treatment depend on initial level of vitamin D? If it gets corrected early, can we shift to maintenance dose? I think we are going to have the expert talk by Professor Zulf Mughal. We would have more detailed explanation on the approach to nutritional rickets. So if it is okay, we'll move on to the next session, ma'am.
Yeah, Sirisha, can you take that last question, because I think that
why is toss Okay.
Therapy is not
Why STOS
recommended.
therapy is not recommended now? It was the easiest step to management before. Yeah, so as far as my knowledge goes, like the studies have shown that there are in few children, the STOS therapy, especially if you're talking about the 6 lakh units of IM injection, it can result in significant hypervitaminosis, and that induces hypercalciuria and even the risk of nephrocalcinosis, even if it could be temporary. That might not be temporary. It might not be temporary. It might cause lasting damage on the kidneys also. So we don't know which child is going to respond in such a way. So we cannot take the risk when we have other easily available oral preparations, which we can ensure the compliance with, even with the weekly doses. If weekly dose is also considered as STOS, but much smaller than the 6 lakh units. So we don't recommend the 6 lakhs IM injection anymore, but weekly STOS doses in older children we do use, not in younger children. In younger children still we prefer daily replacement.
But in this 2021, they are telling to give once in 2 weeks, not weekly.
Yes, ma'am. Yes, ma'am.
Yeah. Thank you very much. Yeah. I think we can move on.
Move on to the next session. Yeah.
If you can stop sharing, Harshita.
Neelam, can you share the CV slide, please?
I think Dr. Shaila ma'am has introduced Dr. Professor Zulf Mughal. His next slide. So he has been he's trained. Professor Zulf Mughal has trained in Liverpool and Manchester in UK and Cincinnati in USA, and he has a number of publications to his credit, more than 180 peer-reviewed scientific papers and reviews and chapters. And he was awarded Charles Lemenda Award in the 7th International Conference in Children's Bone Health in Salzburg, as well as he received the Dent Award by Bone Research Society for his contribution in pediatric bone research. So without further ado, I request Professor Zulf Mughal to take over the podium. Floor is yours, sir.
Thank you very much. I'll just share my slides. Okay, so thank you very much for your very kind invitation, and it's very nice to see Shaila, who used to work in our department many years ago. So I'm surprised that I was asked to talk about nutritional rickets in 2022, but I think Harshita's last case exemplified that it is still an important issue. So I hope I can do justice to this important topic, which really should have been an historical disease, but it is still prevalent. I have no disclosures in relation to this talk, and a lot of what I'm going to say has already been covered in the very elegant presentation, last presentation, but we are going to just recap the pathophysiology of nutritional rickets, talk about the clinical and clinical features and non-osseous features, talk about biochemistry and radiological investigations, and then some work that we did in the UK on how common nutritional ricket is in this day and age, talk a little bit about international consensus guidelines for prevention and treatment of nutritional rickets, and of course, well, I think the last is really, we should really prevent this condition. So rickets is a condition which affects the growth plate and the osteoid. Osteoid is the unmineralized matrix which covers the bones. And in a growth plate, let me just get my pointer done. So in the growth plate, you have these resting chondrocytes, which under myriads of local and systemic hormonal signals continues to multiply, and these chondrocytes align themselves into columns. They undergo hypertrophy, and these hypertrophic chondrocytes have to undergo apoptosis to trigger the whole process of mineralization. And inorganic phosphate level in the plasma or serum plays a crucial role in this process of apoptosis and mineralization of the osteoid. And remember that the hydroxyapatite crystals that we have in the bone and the teeth contain both calcium and phosphate. So when you have vitamin D deficiency or dietary calcium deficiency, you get rise in plasma parathyroid hormone, which then acts on the proximal renal tubule and causes renal phosphate loss. And when you have chronically low phosphate levels, then you get impaired apoptosis of terminally differentiated chondrocytes in the growth plate and failure of mineralization of the osteoid. And this then really results in your the growth plate, which is absolutely full of these large chondrocytes, and which in part sort of explains the classical sort of clinical sign that you see, which is a widening of the metaphyses and this cupping and fraying and widening of the metaphyses that you see on the standard radiograph. And as we've heard, that vitamin D is very, very important, whether you get vitamin D by the action of solar ultraviolet B radiation on your skin, or from diet or from supplements. It's converted in the liver into 25-hydroxyvitamin D, which is a major circulating form of this metabolite, which has half-life of several weeks, and therefore we can use this to measure an individual's vitamin D status. So when we're measuring individuals' vitamin D status, we never measure cholecalciferol or ergocalciferol. We actually measure 25-hydroxyvitamin D. Under the action of 1-alpha-hydroxylase in the kidney, it gets converted into 1,25-dihydroxyvitamin D, or the active form of vitamin D, which then acts on the gut to facilitate calcium and phosphorus absorption. And by maintaining normal serum calcium and phosphate in the plasma, it allows mineralization of the growth plate and osteoid. We know that vitamin D probably has a passive effect on mineralizing the skeleton, because in conditions like vitamin D dependent rickets type 2, where 125 levels are very high, but there is end organ resistance to the action of 125 at the receptor level, you can heal those patients' rickets by giving infusions of calcium or giving them very high doses of oral calcium. And there is a degradation pathway, which is equally important, but we won't talk about this today. We heard a little bit about what are the definitions of vitamin D sufficiency and insufficient deficiency. And this is taken from the international consensus statement, which I'll talk to, and which is very similar to what Harshita mentioned in her previous talk. And the factors which lead to low vitamin D levels or cause nutritional rickets are prolonged breastfeeding without vitamin D supplements in mothers born to infants born to vitamin D deficient mothers, living in northern and southern latitudes. So my city of Manchester is 54 degrees north, and we live in vitamin D winter. So from mid-September to mid-March, we don't see any cutaneous vitamin D. Pigmented skin, of course, reduces the cutaneous vitamin D, and then sun-blocking creams, atmospheric pollution, sunshine avoidance for religious or cultural reasons, obesity, fat cells have this propensity to soak up 25-OHD and not release it, low calcium diet, and genetic propensity. So I'm just going to touch a little bit on the role of breast milk, the atmospheric pollution, and low dietary calcium. We'll start with pollution. So my city of Manchester in 1840s looked something like this. And many of the children sort of worked in sort of mines. And of course, rickets became the English disease during the Industrial Revolution. And virtually 100% of children at one stage in one of the hospitals, which no longer exists in Manchester, had some signs of rickets. In turn of the century, my registrar, Dr. Jacob Tulliel, who basically returned back to Delhi and worked at St. Stephen's Hospital, wrote to me. In those days, we didn't have email, to say that we have lots of rickets in Old Delhi. And so I came down and we looked at the role of atmospheric pollution in determination of vitamin D. And so we looked at, I just need to move this. Thanks. Yeah. So we looked at the UVB reaching the ground level in high pollution and low pollution area in children who had very similar socioeconomic background, very similar diets. What we found that in children in high pollution areas, the serum 25-hydroxyvitamin D was lower than those in the low pollution area. And these patients obviously had higher parathyroid hormone levels. And in those days, obviously, these measures, you had these vehicles which are spewing out a lot of pollution. And breast milk, so this is a very old paper that we wrote, which was a number of infants who presented with very severe rickets. And the key features was that these infants up to the age of 2 years were being fed on breast milk, human breast milk, without any vitamin D supplements. And they had florid rickets, as you can see from the biochemistry, with very, very high alkaline phosphatase, very high parathyroid hormone levels, and very low serum 25-hydroxyvitamin D, showing that they were vitamin D deficient. So why is this an issue? Well, this is a study done by one of our medical students who is now almost a professor of obstetrics and gynecology. Did a lot of seminal work on the human parvovirus. What we did was we looked at the serum 25-hydroxyvitamin D or vitamin D status in veiled ladies of Arab origin versus white Caucasians. And you can see that the maternal 25-OHD levels were very, very low, and in comparison with the white Caucasians. More importantly, the breast milk content of the calcium content of the breast milk was about 16% lower in vitamin D deficient mothers as compared with the vitamin D replete mothers. So it may be that it's the calcium in the breast milk which is important. So if you're lactating and you're vitamin D deficient, then the breast milk quality is going to be affected. And this is a study from Tom Thacker and his group from children with rickets from Nigeria, where they looked at the breast milk calcium content from the mothers with rickets and mothers without rickets, and again showed that the breast milk calcium content was about 10% lower. And which is another very interesting thing, is that we know that the calcium content in breast milk declines as the lactation proceeds, and the decline in the calcium content of mothers whose infants or children had rickets was much greater. So again, speaking to the calcium content in breast milk being possibly important. And then, of course, we've talked about vitamin D, but as I mentioned, that the crucial role of vitamin D is in facilitating calcium and phosphate absorption. So this is a study by John Pettifor from South Africa, where they showed that rickets in these children developed primarily due to very low dietary calcium intake in the face of normal serum 25-hydroxyvitamin D. Because of abundant sunshine, they had very high or satisfactory levels of 25-OHD, but very low, chronically low dietary calcium intake. And then studies from Nigeria, from Tom Thacker, to show that in these children, you could actually heal their rickets by just giving them sufficient quantities of calcium. This is a case report of a child who we saw a few years ago, who was a male infant born to a mother who basically, again, came from she was completely wailed, and this infant was breastfed from birth. When he was weaned at the age of about 6 months, he developed a severe allergic reaction to eggs, fish, refused to take the hydrolyzed infant formula milk. Again, when they tried to introduce milk, again developed allergic reactions. So he was weaned on pasta, rice, potatoes, and small amount of meat, all of which were not very good sources of vitamin D. But he took multivitamin supplements called Dalavit, which contain 400 international of vitamin D2 or ergocalciferol, and presented at the age of 19 months with delayed walking. And as you can see, the radiograph showed sort of florid radiological changes of rickets. What's interesting is that this patient's serum 25-hydroxyvitamin D was normal, and most of this came from D2, which was in the supplement here, but the PTH was high, which then caused the low serum phosphate, which was probably responsible for this rickets, and the alkaline phosphorus is very high. And as has been mentioned previously, that the calcium is often normal in these patients, at the cost of demineralizing the skeleton. So we also see dietary calcium deficiency in the UK. And this is a study, some of you may know that for about 12 years, I used to come once or twice a year and did sort of studies with Anuradha and Vaman Kadilkar in Pune. And this is one of our studies which we looked at, the vitamin D status of adolescent girls in Manchester and Pune. Pune is 18 degrees north, Manchester is 54 degrees north, very similar ages. If you look at the serum 25 hydroxyvitamin D, in those days, the cutoff was 12 nanograms per ml. Oops. They were very, very similar, but the PTH level and low calcium so much higher in the Pune girls. Symptomatic symptoms of aches and pains and genu valgum and genu varum was again higher in the girls from Pune. Dietary calcium, vitamin D intake was very, very similar. The main difference was the dietary calcium intake. Now, we did not in Manchester look at the total dietary calcium intake, but that alone from milk sources was 400 milligrams, whereas in Pune, it was really woefully low at about 65 milligrams, the total being about 450. So it really shows the interaction between calcium and vitamin D. So I think in the Pune girls probably had more symptomatic rickets or symptoms of rickets or osteomalacia due to low dietary calcium intake, whereas in Manchester, calcium had a protective effect. And there's a very nice, elegant study from Delhi, which was a case control study showing that insufficient serum 25 hydroxy vitamin D deficiency sort of caused rickets only in the presence of low calcium intake. So there were two groups of insufficient children with insufficient level of 25 hydroxy vitamin D, as shown here. The calcium intake was approximately half in rickety group as compared with the healthy controls, and that from the dairy was again much lower in the rickety groups. So even though the 25 OHD was not woefully low, but rickets only occurred in those who had low dietary calcium intake. Again, speaking to the fact that calcium plays an important role in the pathogenesis of rickets. And as was mentioned in the discussion of the previous talk, please don't rely on serum calcium level in assessing somebody's dietary calcium intake, because there are so many physiological systems which rely on normal serum calcium. So the body will try its best to maintain normal serum calcium, even in the face of low dietary calcium intake. So you do need to take a good dietary history when assessing somebody's dietary calcium intake. And this is another study that we did in Pune, one of several studies looking at dietary calcium intake in lower and upper socioeconomic children. And you can see that even in those from the upper socioeconomic strata, boys and girls had really quite low dietary calcium intake. And there was a marked gender difference both in upper and lower socioeconomic groups, with girls, especially in the lower socioeconomic group, actually having very low dietary calcium intake. Furthermore, a lot of this calcium came from green leafy vegetables and pulses. So the green leafy vegetables have oxalic acid and the pulses have phytic acid, which really affect the bioavailability of calcium, whereas the dairy products have actually very good bioavailability. So again, it's very, very important to look at diet and also what are the sources of calcium when you're evaluating somebody's dietary history. So this slide really is again taken from the international consensus, which really talks about the mineralization of the osteoid and the growth plate. The sunshine, the vitamin D is denoted by the symbol of sun, and calcium by the glass full of milk. And ricket and osteomalacia really only arises when you have a deficiency of both dietary calcium intake and low vitamin D levels, or whether you're deficient in one and insufficient in the other, either calcium or vitamin D. So please always think of both vitamin D and calcium when you're looking at nutritional rickets. What are the clinical features of nutritional rickets? Well, we've actually seen that in the previous chart. So they often have this marked degree of frontal bossing. And these children are very, very irritable. And there are some animal studies to show that they actually have slightly raised intracranial pressure. We've talked about the widening of the metaphyses. The soft bones become bendy when the child stands up. The classical rickety rosary that you say due to swelling of the costochondral junctions. Then the eruption of primary teeth may be delayed by beyond sort of 10 months. And you need to look at the teeth very carefully. So here you can see that there is enamel, only sliver of enamel covering the tooth. This is unexposed dentine. So this is enamel hypoplasia, which is again a feature of nutritional rickets, whereas in hypophosphatemic rickets, you will get dental abscesses. And of course, we talked about the radiographs. And the adolescents will often present with genu valgum or genu varum. The radiological signs may be less florid because the growth plate is about to close. And you may see this series of this impaired mineralization of the tooth, which is giving you this sort of almost a history that this child may have become deficient and replete during the course of his or her growth. They often have lower limb deformities as shown here, but also pelvic outlet narrowing, which may lead to childbirth. One of the areas where we did a very large sort of vitamin D supplementation study to try and prevent pneumonia was in Kabul, Afghanistan, where sadly we found that a lot of mothers actually died due to childbirth because of possibly because of the obstructive pelvic outlet. Now, one of the things which adolescents particularly get is this myopathy. So muscle weakness is an important feature of rickets. There was some discussion about the assessment of genu varum and genu valgum. I think it's very important to remember about the development of the tibiofemoral angle, which is this angle here, which you can measure using the goniometer. As a child sort of in early infancy, you have more sort of physiological varus deformity. And then as a child gets older, you get sort of valgus deformity. So if you get sort of rickets developing in this phase, you're more likely to get varus deformity. In an older child around about here, you're more likely to get valgus deformity. Now, how do you assess the degree of the varusness or valgusness? Well, it's easier measuring the intermalleolar distance. It is much harder to look at the varus deformity. And I don't tend to sort of feel for the tibial tuberosity because in sort of obese or overweight children, it's often very difficult to define. We all have these two vertical creases behind our knees, and I just tend to measure this distance. And the physiological upper limit of normal for intermalleolar distance is about sort of 5 centimeters. So if it's greater than 5, then it's likely to be pathological. I tend to add another ½ centimeter to this because of you're not measuring from the tibial tuberosity to tuberosity here. So I was going to show a video of proximal myopathy, but unlike Dr. Kulkarni, I wasn't able to get my videos to work when we did the rehearsal yesterday, but this is one of the studies that we did in Manchester many years ago, where we took about 91 postmenarchal girls, measured their 25-OHD levels, and as a group they had lower mean values, but they were all asymptomatic because they had good dietary calcium intake. And we got them to jump on this force plate, which measures the height of the jump and velocity of the jump and the power of the jump. And then supplemented them with ergocalciferol. This was directly observed treatment, 150,000 units every 3 monthly. and this led to normalization of the serum 25-hydroxyvitamin D in the intervention group as compared with the placebo group. What we found was that on those who were in the intervention group, there was a marked improvement in the jumping height, the jumping force, and the velocity, confirming that vitamin D deficiency affects muscle function. The non-osseous features of nutritional rickets are, of course, hypocalcemic tetany and seizures, particularly in young infants. One of the most devastating complications is this hypocalcemic dilated cardiomyopathy. This is a chest radiograph taken from failed resuscitation of a child, an infant who was born to a mother who herself was profoundly vitamin D deficient. This child was breastfed and not given any vitamin D supplements, presented at the age of about 3 months with increased work of breathing and seizures, and really suffered a cardiac arrest. And in spite of best efforts to resuscitate, and you can see an intraosseous needle in the proximal tibia, the child died. You can see a large heart with fluffy lung fields due to heart failure, and this classical signs of rickets. The other features are pain, pathological fractures, delayed motor development due to myopathy, and this irritability that these children have, which is possibly due to mild raised intracranial pressure. And recently we've sort of published a series of cases of nutritional rickets presenting with craniosynostosis, which is more commonly associated with hypophosphatemic rickets. So what about approach to diagnosis? Well, as we've heard in Harshita's elegant talk, that you need to take a very detailed history, which is always a cornerstone of a good clinical assessment. A family history and inheritance is very important, because you may be dealing with one of the inherited forms of rickets. Is a history of sunshine avoidance. What's their dietary calcium intake? Is there failure to thrive, polydipsia, polyuria, which might point to renal tubular acidosis? Is there dental enamel hypoplasia or dental abscesses? Is there a history of nephrocalcinosis or renal stones? That may be, again, a feature of some of the Fanconi syndromes, or Dent's disease. Is there a history of renal failure? Again, Dent's disease. There may be a history of renal replacement therapy, or renal stones, which you might also find in other forms of hypophosphatemic rickets. For example, hypophosphatemic rickets with hypercalciuria due to mutations in the SCLC34A1, which is a sodium-dependent phosphate transporter in the renal tubule. Oxology is very important, good height and weight measurements, assessment of genu valgum, genu varum, as we mentioned, and a quick musculoskeletal examination. Always examine the teeth. Teeth are important part of heart tissue. So if you're examining the limbs, always look at the teeth for evidence of enamel hypoplasia, as I mentioned, or dental abscesses, and of course, radiology and biochemistry. So I think your panel of, oops, this is a typo here. This was meant to be biochemistry, but you should measure serum calcium phosphate alkaline phosphatase. Always important to look at sodium phosphate bicarbonate in case you're dealing with Fanconi's, in which case you may sort of see low bicarbonate, and potassium may be low. Parathyroid is the key hormone to actually measure. Serum 25-hydroxyvitamin D to measure the vitamin D status. I tend to sort of ask our lab to save the serum, because if I need to subsequently measure 125, I've got something saved there to measure it, because once you start treating, you may not have the pre-treatment serum available. I think urine dip slide is very important. So if the child is producing alkaline urine, or there is glucose, potassium, or protein, this makes you think of renal tubular acidosis, Fanconi's, Dent's disease, etc. And of course, radiograph of the wrist or the knee. Our orthopedic surgeons like to get standing long leg radiographs if they're going to plan some treatment, particularly in adolescents who may not have enough time, but the growth plates are open. They might use hemiepiphysiodesis or guided growth treatment to correct the deformities. I have to say that in young infants and toddlers, there is really no need to sort of subject them to any surgery. There is enough time for them to remodel and heal their deformities if you treat them adequately. So what's the biochemistry that you see in patients with rickets? So as your serum 25-hydroxy starts to go down, your 125 transiently goes down and your calcium starts to drop, but you don't actually see that because the homeostatic mechanisms kick in. In other words, PTH starts to rise, which increases 125 dihydroxy vitamin D level, restores the diet, causes increased dietary calcium absorption, and in early vitamin D deficiency, your calcium is normal. But that high PTH is acting on your kidneys and causing internalization of the sodium-dependent phosphate transporter A and C, and so you are now not reabsorbing the filtered phosphate, and you're starting to lose phosphate in the urine, and so your phosphate starts to go down. And as I mentioned, phosphate is the crucial ion in promoting the mineralization of the growth plate and the osteoid. So when there is failure of mineralization, your alkaline phosphatase goes up. So to sum up, in early rickety changes, your calcium will be low, low normal, phosphate will be low, alkaline phosphatase will be high, 25-OHD will be low, PTH will be high. I don't recommend you measure 125, but if you do, it will be very high. Now, once you've really exhausted your 25-OHD, you then get into this severe vitamin D deficiency. The PTH is now trying very hard to act on this substrate, which is really hardly there. And at this stage, the 125 starts to fall, and the calcium now starts to fall because there is, there is 125, which facilitates calcium absorption, is starting to fall. So the phosphate is even lower because the PTH is higher, the alkaline phosphatase is high. But as we know that nothing in medicine is straightforward. So there are patients where you get this PTH resistance who present with low calcium, high phosphate, very low 25-OHD, very high PTH, and very low 125. In fact, we often get calls that I've got a patient with pseudo hyperparathyroidism who's got low calcium and high phosphate. And my first response is, have you measured 25-OHD? Because my view is that you cannot make the diagnosis of pseudo hyperparathyroidism without first excluding nutritional vitamin D deficiency. Now, why does this occur? Well, I think the clue for this actually came from these studies that we did in, again, Pune, where we found that oral calcium supplementation reversed the biochemical pattern of parathyroid hormone resistance in underprivileged Indian toddlers. And so when you have either chronically low dietary calcium intake or severe malabsorption of calcium due to low 125, you actually get this PTH resistance. As soon as you start treating these patients with calcium and vitamin D, the calcium goes up and the phosphate often drops quite precipitously in these patients before it sort of normalizes. So again, showing the importance of calcium in explaining some of the pathophysiology that we see in these patients. I won't talk so much about this because we've talked about this, but I will mention that if you see a child who has got rickety changes but no osteopenia or no this hyperparathyroid response, so you can see an extra line here, and that is due to subperiosteal bone resorption by the PTH, then think of a hypophosphatemic rickets or XLH who actually get sclerotic bones, and they get this increased metaphyseal sclerosis. Some of the adolescents, older adolescents may get these looser zones, which is, these are sort of pseudo fractures that you see on the inner aspects of the proximal femur, sometimes in the pelvis as well, present with severe pain. So how common is nutritional rickets? And this is really was quite an important question for us, because we, as the British Pediatric and Adolescent Bone Group, have been sort of lobbying our parliament to sort of do something about supplementation. But there was, every time we went to see the politicians, they would say, well, tell us how common it is, first of all. And so as part of the British Pediatric Surveillance Unit, we carried out a survey of nutritional rickets in UK and Republic of Ireland between March 2015 and March 2017. And the case definition of nutritional rickets was age under 16, radiological evidence of rickets, which was confirmed by a card-carrying pediatric musculoskeletal radiologist, low serum 25-OHD, less than 25 nanomoles per liter, and supporting biochemistry with raised PTH, raised alkaline phosphatase, low or normal calcium or phosphate. And history suggesting of rickets and exclusion of genetic causes of rickets and rickets of prematurity and skeletal dysplasias mimicking rickets such as Schmidt's dysplasia. And what we actually found was that surprisingly, rickets was not as common as we thought. The incidence was about 0.5 children per 100,000, which is making it as common as sort of rare bone disorders like XLH that we have. But majority of the children were from Black, Asian, and ethnic minority group. Over 75% were not taking any vitamin D supplements. More than a quarter of them had sort of delayed motor development. About 10% had fractures, 8% hypocalcemic fits, and 3%, rather 2 children actually died of dilated cardiomyopathy, which is, I think, a matter of great shame. We regard ourselves as the 6th richest country in the world, and in this day and age, we are having children dying of totally preventable disease. And how did this compare with other countries which have sort of done systematic analysis of the nutritional rickets? So there are studies from Canada, Australia, and New Zealand, and the annual incidence is different compared with that in the United Kingdom and the Republic of Ireland, but the criteria of definition of rickets was different in all 3 countries, which may partly explain the different prevalence the things. I think it would be interesting to know how common nutritional rickets is in India. So I'm finally going to talk about the International Consensus Guideline for Preventional Treatment of Rickets. So this is this was an international group which met to sort of critically review the available literature, grade the quality of the literature, and the experts from various societies, including ISPAE, as you can see here, met for 2 days in the city of Birmingham to come up with the guideline, which is published in JCEM and is available free of charge. And this really provided sort of the evidence-based sort of guideline on treatment and prevention of rickets. And this is very similar to the IAP guidelines which were mentioned. I should have done my homework by referring to IAP guidelines than this, but these are the sort of treatment, sort of daily sort of doses of vitamin D3 suggested for treatment. The stool therapy was kept in mainly because in many resource-poor countries, it was felt that the follow-up was probably not as good, and you had to opportunistically treat these patients, whereas those of us who are from the UK, Australia, USA felt that by far the majority of children could be treated by giving daily doses of vitamin D. It suggested that you should treat for about 12 weeks and then reassess. It's vitally important to ensure at least 500 milligrams of calcium, which in my opinion is quite conservative, because when you get this rickets, you get this hungry bone syndrome. And initially you need to actually give tons of calcium. And in terms of monitoring, I would say that Hershmitter sort of gave very nice sort of guideline on monitoring, but I would actually add parathyroid hormone, because I sort of tend to see fall in the parathyroid hormone as an important marker, which occurs before the alkaline phosphatase settles down. And in my opinion, alkaline phosphatase is not as sensitive in older adolescent patients with nutritional rickets as it is in younger ones. So I would sort of normalize the PTH. After all, that is what's causing the renal phosphate loss, which is, as I mentioned, important in the pathogenesis of rickets. In terms of prevention, There was a big debate about 400 units or 600 units. The IOM, the international, the Americans and Canadians suggested 600 units, but the overwhelming evidence was that if you gave 400 international units well, it's important to supplement pregnant ladies as well, but also young infants, regardless of whether they're breastfed or formula fed, and ensure dietary calcium intake of 500 milligrams, then the evidence was fairly strong in preventing rickets. So really, I'm going to summarize by saying that nutritional rickets is a disorder of impaired mineralization of the growth plate and osteoid. It may arise from deficiency of vitamin D, dietary calcium deficiency, or more commonly from combination of both these two nutrients. And besides causing skeletal and dental manifestation, please remember that it causes skeletal muscle weakness. I've seen girls who sort of come in almost in the wheelchair during my visits to Gulf area, and often just treatment of these patients with vitamin D, they sort of literally get up and walk. So it can cause profound muscle weakness. A severe vitamin D deficiency in infants can cause hypocalcemic seizures, and this potentially fatal dilated cardiomyopathy. And there is evidence-based international guideline for treatment and prevention of rickets. As I said, it's in 2022 we are still talking about this, and really nutritional rickets is an entirely preventable disease, and it must be eradicated with vitamin D supplementation and adequate dietary calcium intake. I think we should, my hope is that we will sort of stop talking about rickets, nutritional rickets, and talk about other more challenging disorders, but it's still there. And Harshita's case sort of amply sort of exemplifies that we still need to think about this. So I thank you for listening to me, and I'll be happy to answer any questions.
Thank you so much, Professor Mughal, for that excellent presentation. We feel that for our scenario, we do feel that it's a common condition and we know most of it, but we realize that every time we have a lot more to learn, a lot more new aspects of the same common condition to learn. So I'll just check the chat box for any questions.
Nutritional rickets is still like unimaginably more common in our country still, Dr.
It'd be interesting to know. You see, we had this impression that it was very common, but when we started looking into this, it turned out to be not as common. And we thought we'd go to the parliament armed with all this evidence. Why can't we have free supplements for everyone? And I took out one slide. We actually did quite complicated health economics to show that, in fact, it was cost effective to prevent rickets through supplementation, given all the health resources which were used to treat, not to forget the mortality.
I have a couple of questions, Professor. Would it be, is the food, are the commonly used foods supplemented with vitamin D and calcium, and consumption of more of store-bought food is?
Yeah, so I think not in the UK. So as you know, in many countries, Canada, United States, and now in the Republic of Ireland, the milk is supplemented by law with vitamin D. The only food which is supplemented in the UK, the only foods is margarine. In fact, children hardly eat any margarine, so it's not a very good source. So I think supplementation is very important. So one of the studies that we did in underprivileged children in Pune, which I could have alluded to, was in having laddus, the delicious Indian sweet, and we had supplemented them with vitamin D and calcium, and we showed very nice improvement in this thing. So this again in underprivileged children, but then we got criticized for using sugary sort of snack for the thing. So, but I think it shows that it is possible to optimize vitamin D levels through supplementation. It's just that you probably need to use something other than laddus to actually supplement,
So So Dr. Raghupati is asking, when the family food intake is common, including milk intake, how to explain the development of vitamin D deficiency and rickets in one child, but not in the other siblings?
That's a very good question. I don't know the answer, but what we actually found was that, and again, that may not be prevalent in the whole of the India, but sadly, we found that there was a marked gender difference in provision of dairy within the families. So this is going back to about 10, 15 years ago, and things may have changed now, but the dairy products, milks, curds and cheese were more likely to be given to boys than girls in some families that we looked at in Pune, and that might partially explain that perhaps it was preferentially given to boys and not to girls, and that might explain why it's more common, but I don't know the answer to that question.
And in your practice, like even though cases are less, is universally daily treatment, the replacement of vitamin D is mostly on a daily basis, or do you also follow weekly or once in a month?
Yeah, so I think it's a good question. So I think for toddlers and infants, there is not an issue. I think daily works very well, and because the parents will by and large sort of administer the daily doses of vitamin D. We had sort of outbreak of rickets in one school, which was very conservative school following the practice, and we had to almost institute STOS therapy, oral 3-monthly therapy directly observed by health professionals. So adolescence, as you know, is a big challenge, whether you're dealing with cystic fibrosis, type 1 diabetes, or rickets. They have their own agendas, and they may not actually adhere to taking something daily. And I think under those circumstances, it is safe to actually give oral STOS therapy. I think intramuscular STOS is not a good idea. My late colleague Barbara Moore, who really was one of the doyen of vitamin D, did some very elegant studies with her adult colleagues and showed that the absorption of vitamin D given intramuscularly was very, very erratic. So I think orally it works very, very well. So there is a place. What I think there isn't a place for is when people don't actually fully evaluate the rickets and give 6 lakhs without actually checking it. And there are multiple reports of vitamin D toxicity in countries like Turkey, and I believe from the Indian subcontinent as well, where that has happened. But I think where there's established vitamin D deficiency rickets, then I think giving STOS therapy under supervision and monitoring is probably fine.
One last question from me again. We have a routine supplementation guidelines for under 1 year. Any ideas about routine supplementation for adolescents?
I think it's very, very important. Like you mentioned, at the time, so let me just go back a bit. So 2 years either side of menarche in girls is when 40% of the bone mass is going to be laid down. And during this time, this crucially important time, many of our adolescent girls said, oh, no, milk is bad. They go off dairy, they go off milk, they develop all sorts of ideas about things. And I think that is a matter of great concern. And I think there's a lot of education which needs to be done. And, we have done quite a bit of work in this area. And it's very challenging. It's very challenging because these are very articulate young men and ladies, who are on the road to become adults, and they have their very, very fixed ideas. So I believe it is important. I believe it's a lot harder to actually deal with them because you need to just change their mindset about this, even when there is plenty of supplements available, but yes, I believe that's very important. Yes.
Thank you, sir. Divya, if I'm missing anything in the questions, can you please?
Yeah, one question from Varsha. So there in Pakistan, they have like 2 lakhs IU vitamin D preparations, and then they have only 4,000 IU available.
400.
Yeah, 400 IU available. So how to?
I honestly don't know. I think as I said, you know, I think this, whether it's 6 lakh or 2 lakhs, etc., it's if they're given uncritically without any evaluation, it can be dangerous. Now, when I used to come to Pune regularly, we used to find that some children were probably seen in clinics and they just noticed a little bit of chubbiness and were given 6 lakhs. And I think that sort of practice without proper biochemical evaluation is thing. So I cannot comment on that. I think vitamin D is sort of so cheap to make and so cheap to manufacture. I would have thought that, you know, it should be possible to get sort of different ranges to cater for infants, toddlers, and adolescents. But every country has different preparations. These days, I go to the Gulf area quite often, and they all have different preparations available. So it's difficult to comment about what's available in different countries. Could I comment on Neocate, which came up in the previous talk? So. Neocate is an interesting thing. So Neocate, in the older preparations of Neocate, the phosphate supplement that was used was really very poorly absorbed, and there was reports both in Canada, USA, Republic of Ireland, and then my colleagues from the British Pediatric and Adolescent Bone Group also published a paper. And it is almost unique to Neocate, not to other elemental feeds. And in states, there was a class action, you know, in the law courts taken against the company that makes Neocate. So I think, I believe that Neocate have changed their formulation, and it may not be a problem, but it was a point which was very well sort of made about Neocate as a risk factor, and I thought I would just comment on that. And I've seen at least three infants with Neocate-induced hypophosphatemic rickets. And the TMP-GFR is very important because these patients really absorb every ion of phosphate that is filtered, as opposed to other forms of hypophosphatemic rickets where they will be losing phosphate, you know.
I think the preparation, if I can add on that, the preparation that's available in India is not yet changed. Only last year we have reported 2 cases, premature infants, where we're struggling with phosphorus. The moment we changed Neocate to another formula, it just took 48 hours for the phosphorus to shoot up.
Interesting. So I think you should ask them to change the formulation, especially if there's class action being taken in states, you know.
And sir, I mean, what is your opinion, like, you know, how long the treatment to be monitored, or the bolus doses of vitamin D to be given, like, you know, for how long, which is you said PTH to be monitored, I mean, which help in the management, but PTH is like kind of an expensive investigation in our.
No, I realize that. And I think Harshita actually covered it very nicely. She showed the sequence of events. So in my opinion, the first thing that parents report is that the irritability goes. You know, these children who are really quite cross, possibly due to raised intracranial pressure, become calmer. They also sweat a lot, you know, possibly due to pain. It's just like, you know, our patients with osteogenesis imperfecta. The first time we give them bisphosphonates, the parents often report, oh, you know, the bedding at night is no longer covered in sort of sweat because of sweating. And the patients with rickets also have this sweatiness, irritability, pain, and that sort of improves within a week or so. And then you sort of start seeing your biochemical improvement, you know, the phosphate starts to rise, the alkaline phosphatase starts to come down, the PTH goes up. And because PTH is available more easily, I use that as an important biomarker, because I know that as soon as I've normalized that PTH, I'll shut down this tap, which is causing phosphate to be lost. there is no place for measuring 125. If you measure 125, it will be very, very high. But as I said, I often ask the lab to actually keep the serum in case I want to go back and measure the pre-treatment 125 levels. The radiological monitoring, I would not do too many radiographs. I would do a radiograph 6 months later, just to ensure that the healing's taken place. Some people might say 3 months later, because by 3 months, if you haven't shown the sclerosis happening, then and biochemistry not improving, and that you need to sort of say, hang on a minute, this is not, doesn't sound like nutritional now. Now to think of vitamin D dependent rickets type 1, type 2, or possibly hyperphosphatemic rickets. But there are other clues to hyperphosphatemic rickets. The PTH is never high in hyperphosphatemic rickets. It may be slightly high due to inappropriately low 125 levels. So the deformities usually in a toddler take about 2 years to completely get better. In adolescents, they may never get better because there is not enough time for bone remodeling to take place. And there is a role to actually ask your friendly orthopedic surgeons to consider doing hemiepiphysiodiasis before the growth plates completely close up, you know, and you can get very nice alignment, mechanical alignment of the lower limbs.
Thank you, sir. Any further questions? One more question can we take, madam? Parvati has asked, so hepatic osteodystrophy, I mean, like, you know, what should be the vitamin D supplementation prior to the liver transplant?
So I don't have much experience of that, because in the UK, the designated liver centers are King's College in London, Birmingham Children's Hospital, and Leeds used to be one of the centers. So I don't think so. But when I was in Cincinnati, we did a lot of work on the thing. So I think the hepatic dystrophy, osteodystrophy is a combination of both, you know, the inability to make 25-OHD. 125 levels are also often low in these patients for the reasons which I don't fully understand. It may be due to the hepatorenal connection, but the bile salts are very important for absorption of calcium. So, you know, when you're not making bile salts, then you get calcium malabsorption. So my simplistic approach is that you need to normalize everything, you know, give them enough 25-OHD. If 125 is low, then you may need to give them something to normalize that, and they need adequate amount of calcium to normalize it. It's just reminded me about what Dr. Bodu mentioned about the increase of vitamin D deficiency during lockdown. So every now and then we sort of link up with Vaman Khadilkar's trainees to discuss some of their bone patients. And we did this about 2 weeks ago, and they presented a very interesting girl, a young lady, who really didn't go out during lockdown. And for some reason, there must be some problem with her diet, and she presented with a limb. And when they did radiographs, she had actually bilateral femoral fractures and severe osteomalacia. And they thought that the lockdown might have contributed to this. So I was very interested in your comment about lockdown having caused increasing adolescent rickets, you know, which is something we haven't seen in the UK, you know.
Shaila ma'am,
yeah, actually in India, the lockdown extended for 2 years with no schools, whereas UK, they opened up in between and it was, but here the schools have still not started in full-blown school. It will be only in June, 2nd week and 3rd week. So they are still at home, actually, all the adolescents and younger kids.
So I think that's it's important to sort of ensure that they are probably not overeating and doing some exercise. More importantly, taking calcium and vitamin D. You know. Well, thank you.